So, how you are going to manage hard impacted stool in a patient who is bedridden or with multiple comorbidities? The drug of choice is phosphate enema. However, if the patient is healthy and young and no other comorbidities, then we will try glycerol suppositories first. So, in elderly patient with hard impacted stool, phosphate enema. In young patient with hard impacted stools, glycerol suppositories. However, if the stools are hard but not impacted, then we will give stool softeners. Constipation with soft stools.
Dr. Shah, can you please um, explain about this constipation treatment one by like in stepwise, because it's quite confusing when you go to the pregnancy for constipation treatment. It's different from the one which is here, so they all get mixed up. So like stepwise, if you just explain that what to be used first and then what to be used next. Thank you.
Okay. So first of all, we will manage constipation in elderly patient who are in nursing home or who are bedridden for a very long time. If they present to you with hard impacted stool, then you will use phosphate enema. But if the patient is young and he complains of hard impacted stool, then glycerol suppositories. This is the management of hard impacted stool in elderly patients and in young patients. Now, let's discuss the management if the stools are hard but not impacted. Then we will use stool softeners. Now, constipation with soft stools. First line is high fiber diet. Second line is stimulant laxative. And third line is osmotic laxative such as lactulose or macrogol. So constipation with soft stools, first line is high fiber diet, second line is stimulant laxative such as senna, then third line is osmotic laxative such as lactulose or macrogol. In pregnancy, there is a slight difference in the management. In pregnancy, lactulose or osmotic laxative are used before stimulant laxative, while in normal population, stimulant laxative such as senna is used first before lactulose. Otherwise, all other management is same. First line is stall husk or high fiber diet. Second line is lactulose in pregnancy, while in normal population, second line is senna or stimulant laxative. And third line is lactulose in normal population and senna in pregnancy.
Could you explain why this is the case in pregnancy only?
In pregnancy, if we give stimulant laxative first, it can lead to increased peristalsis, and there's already a baby in the abdomen, so it can lead to abdominal cramping. That's why lactulose is first preferred over Sena. Dr. Musharat, is it clear or should I
Yes,
repeat?
no, it's clear. Just a question, like for example, in the STEM, they give you both like high fiber diet and isvogol. So what should you pick? Like high fiber diet first, because I was doing one question, and the STEM said like the first line whether it should be high fiber diet or isvogol. So I clicked on high fiber diet, but the answer was isvogol. So I mean, what should?
The question was related to pregnancy,
No, just the normal person.
normal person. So I would like if you share that question in the group, because
Okay.
high fiber diet and whole husk, they are almost same. They will increase the bulk of the stools.
Yes. So that's why I was confused. Like, I mean, if a question like this, it comes in.
Maybe there
Exact.
in that scenario there is something that they selected whole husk. I can only tell you if you share that scenario in the group,
Okay.
then we will
Yeah.
discuss about it.
Yes, I will. Yeah. So it is, so far it is clear. Otherwise, thank
I'll share some scenarios related to constipation as well in the group. So, Dr. Shafraz, you were asking about the spelling of spurious diarrhea, which is also called overflow diarrhea. So,
Yes.
spurious diarrhea is usually bedridden or nursing home patients due to hard impacted stool and seepage of fluid through hard impacted stools. Now, let's discuss a scenario. A woman who has just delivered her baby 3 days ago presents with severe epigastric pain, nausea, and chills. Her BP was normal during the pregnancy and is still normal. Her temperature is 37.3. Urine analysis shows no protein. So, a female who has just delivered her baby present to you with epigastric pain, nausea, and chills. ALT is high, ALP is high, bilirubin is high, ELC count is high, platelet and HB are normal. What is
you.
the most likely diagnosis in this scenario? First of
Acute
all,
co-
tell me which conditions can cause abnormal LFTs during pregnancy or in postpartum period.
Acute
Health,
fatty liver, HELP syndrome.
fatty
Acute
liver,
fat,
and health
yes,
syndrome.
HELP syndrome, acute fatty liver of pregnancy. So, is it AFLP or acute HELP syndrome?
AFLP.
Fatty liver.
Acute
Acute fatty
fatty
liver of pregnancy.
Yes.
What are the laboratory findings of acute fatty liver of pregnancy?
I think the platelets are usually normal.
Mm,
ELLP.
AFLP platelets are normal.
So it's ELLP, elevated
Liver
liver
enzyme,
enzymes,
and
and
LP mean low platelets.
blood platelets. Yeah,
But in this scenario, platelets are normal. So it's not AFLP. HV is also
it's
normal. So it's not HELP
health.
syndrome as well.
Acute cholestasis of pregnancy.
Cholestasis of pregnancy. In cholestasis of pregnancy, the presenting complaint of the patient is usually severe pruritus on palms and shoulders and exocreation of the skin. So it's not cholestasis of pregnancy as well.
Acute cholecystitis.
Cholecystitis, yes, because she delivered 3 days ago.
Yes,
Acute cholecystitis.
cholecystitis is very common in pregnancy. After ruling out other the condition, we are only left with acute cholecystitis. Acute cholecystitis can cause raised ALT, ALP, bilirubin, WBCs are also high. You can see that, and there is pain, epigastric, nausea, and chills.
There's temperature as well.
Yes. So acute cholecystitis. The presenting symptoms plus the recent history of pregnancy make the acute cholecystitis. Why not HELP syndrome? HELP syndrome. In HELP syndrome, there is hemolysis, low HB, but in this case, HB was normal. Low platelets, platelets were also normal, so it ruled out HELP syndrome. AFLP was also ruled out. So in difficult questions in exam, you can rule out the wrong answers like this. And select the option that you are left with. You can, by this way, you can get the difficult MCQs correct or right 90% of the times. So it's not AFLP, not HELP syndrome, not preeclampsia because no hypertension or no protein in urine. Why not obstetric cholestasis or cholestasis of pregnancy? There would be severe pruritus due to increased bile salts. In postpartum period, HB of less than 10 is called anemia. So this was all about cholecystitis during pregnancy, very common condition. Now, severe central abdominal pain radiates to the back and relieves when bending forward plus vomiting.
Acute pancreatitis.
Pancreatitis.
That's right. An old age patient who present to you with weight loss and anemia. Chronic abdominal pain plus bloating plus altered bowel habits such as diarrhea or constipation. You will perform colonoscopy to rule out
Colonoscopy.
colon cancer.
Cancer of
Now answer this one. 55-year-old male, history of worsening intermittent dysphagia, occasional regurgitation of food, recurrent respiratory infections, no weight loss. What is the most likely diagnosis?
Eclasia.
Dysphagia, that's right. Dysphagia plus respiratory infections, eclasia. In pharyngeal pouch, the word regurgitation usually means eclasia or pharyngeal pouch. But in pharyngeal pouch, there will be halitosis,
Gurgling
gurgling sound
sounds.
on drinking, sensation of lump in the throat, neck, or neck bulge. If there was a history of weight loss, we would have think of esophageal cancer, because in this scenario, they haven't mentioned that the character of dysphagia for both solids or liquids, or initially for solids or liquids. So in this scenario, if there was weight loss, then we would have thought of esophageal cancer. Now another question, chronic pancreatitis. The major cause, 80% of the cases of chronic pancreatitis are caused by alcohol. What is the difference between acute pancreatitis and chronic pancreatitis? In chronic pancreatitis, the pain is also radiating towards the back, but the pain is episodic. In the scenario, they will usually mention history of months of the pain. In acute pancreatitis, the duration of the pain is usually days, 1 to 2 days, while in chronic pancreatitis, it will be months or weeks, and also the pain will be remitting and relapsing. What is remitting and relapsing? Remitting and relapsing mean comes and go. So an alcoholic who present to you with remitting and relapsing epigastric pain that is aggravated by eating, and also there's a history of weight loss, because eating aggravate the pain, so the patient is afraid of eating. Therefore, because he is not eating, he will develop weight loss. Also, remember that pancreas secrete the hormones which are required for the absorption of the fats or lipids. So no enzyme will be secreted by pancreas in chronic pancreatitis. So it will lead to malabsorption diarrhea. So an alcoholic present to you with diarrhea, chronic diarrhea, it is most likely chronic pancreatitis. Steathoria. Steathoria is a feature of all malabsorption diarrhea such as in celiac disease and in chronic pancreatitis. How steathoria are mentioned in the Plab 1 exam: offensive and loose stool that is difficult to flush because the fat content of the stool is high. That's why they are difficult to flush. Initially, the patient will have these symptoms, and later on, when the damage of the pancreas is increased, the patient can also develop diabetes and jaundice. Initial investigation is ultrasound and X-ray. X-ray will show abdominal calcification, and the gold standard, as in acute pancreatitis, in chronic pancreatitis, the gold standard investigation is CT abdomen with contrast. Other useful investigation in chronic pancreatitis include fecal elastase and fecal chymotrypsin. Treatment is analgesics for the pain, and as what fat soluble vitamins are not absorbed, so we'll give fat soluble vitamin supplements. And as there is pancreatic enzyme deficiency, so pancreatic enzyme supplementals will also be given. Is it clear to everyone? Chronic pancreatitis. Is there any question? Okay, no question. Vitamin B12 deficiency, its treatment. An alcoholic patient present to you with hematemesis. Two differential diagnoses should come into your mind. One is esophageal varices, and the other one is Milry-Weiss tear. An alcoholic patient who present to you with hematemesis, these two things should come into your mind. One is esophageal varices and other one is Milry-Weiss tear. So if the patient developed hematemesis after severe vomiting, then it is most likely Milry-Weiss tear. And if the patient developed hematemesis with signs of chronic liver disease or stigmata of liver disease such as ascites, spider nevi, jaundice, then it is most likely due to esophageal varices due to portal hypertension or esophageal varices. How you are going to manage a case of esophageal varices? This topic will also be discussed in emergency medicine, but still we'll discuss it here as well. So esophageal varices are basically due to portal hypertension, and patient, if the patient is with the signs of chronic liver disease, then it is most likely due to esophageal varices and not Milry-Weiss tears. Milry-Weiss tear usually develop due to repetitive vomiting. So how we'll manage a case of acute esophageal varices bleeding? First of all, remember that in every emergency situation you need to follow the protocol of ABCD. After initial management, then the medical management for portal hypertension is thoroughly present and prophylactic antibiotic before endoscopy. During endoscopy, we will perform band ligation for esophageal varices and an injection of N-butyl cyanoacrylate for gastric varices. So after ABC and before endoscopy, terlipressin and prophylactic antibiotics need to be given. And then during endoscopy, if there are esophageal varices, then band ligation of the varices, and if there are gastric varices, then an injection of N-butyl 2 cyanoacrylate. If band ligation is not available, then we can perform sclerotherapy as well. And if the symptoms do not improve with the above measures, then we will perform TIPS, transjugular intrahepatic portosystemic shunt, a shunt that is passed through jugular vein and liver between the portal and systemic circulation to decrease the pressure in the portal vein is called transjugular intrahepatic portosystemic shunt. Remember that if the hematemesis is due to varicose bleed, then PPI should not be given. And if the hematemesis is due to peptic ulcer, then PPI can be given. So this was all about a complication of liver cirrhosis or liver disease in alcoholic, which is esophageal varices, which can lead to hematemesis or upper GI bleed and its management. Is it clear to everyone? Is there
Yes.
any question?
So
Sir,
why PPI is not given? Sorry, you can ask.
sir, can you please repeat it again? The management.
Remember, I will answer Dr. Musarat's question as well, that why PPA are not given in esophageal varices. Remember that if the hematemesis is due to esophageal varices and not excessive acid secretion, then there is no need to give PPI, because if we give PPI in esophageal varices, it will suppress the stomach acid, which is basically a protective, because it suppresses the bacterial growth. So if we give PPI in patient with esophageal varices, then it will be harmful, because it will lead to growth of bacteria and which can lead to spontaneous bacterial peritonitis. Basically, the hematemesis is due to varices and not to high acid secretion. So that's why giving PPI is not a wise approach in patient with esophageal varices.
Okay, got it now. Thank you.
So the management of esophageal varices is simple. Remember that in every emergency situation, if a patient is received in emergency, then you need to follow ABCD first. Then you will manage the deformity or the disease at your hand, such as in case of hematemesis, the initial management after ABC is pharmacological treatment is terlipressin and prophylactic antibiotics. Terlipressin basically causes subplanchnic vasodilation, so it reduces the portal hypertension. After that, we will perform endoscopy to provide a definitive cure or definitive treatment, that is band ligation in case of esophageal varices and an injection of the chemical cyanoacrylate in case of gastric varices. But if the bleeding is not stopped with these two measures, then we need to perform a procedure which is called TIPS, transjugular intrahepatic portosystemic shunt. Is it clear, Dr. Sambal now?
Yes, sir. Thank you.
Now a patient present to you with diarrhea What is diarrhea? Diarrhea is 3 or more watery or loose stools per day. Acute diarrhea is less than 14 days and chronic diarrhea is more than 14 days. So a patient with diarrhea, sometimes bloody for 7 days. The patient present to you with diarrhea, 7 days history of diarrhea. So it's acute diarrhea. Though it's bloody diarrhea, we can think of ulcerative colitis or Crohn's disease, but the diarrhea is acute. So first of all, we need to rule out the infectious cause of this diarrhea because the duration of symptoms is 7 days. So the first investigation that you will order in acute diarrhea is stool culture and microscopy to rule out any infectious cause. And if stool culture and microscopy is negative for any organism, then we can go for colonoscopy plus biopsy to see if it's ulcerative colitis or not. Dermatosophagus is already discussed. Gilbert syndrome. Gilbert syndrome is a basically we have discussed different causes of abnormal LFTs. To diagnose Gilbert syndrome, remember that ALT, AST, ALP all will be normal. The only abnormal LFTs in Gilbert syndrome is raised bilirubin. A patient whose ALT, AST, GGT, ALP, all other liver enzymes are normal, but bilirubin is raised, then you will suspect Gilbert syndrome. Gilbert syndrome is an autosomal recessive disease in which there is decreased activity of the enzyme which is involved in the conjugation of bilirubin. And the name of the enzyme is UGT1. So decreased activity of UGT1 can lead to decreased conjugation of bilirubin. So unconjugated bilirubin will be raised. And remember that unconjugated bilirubin is not water soluble. So unconjugated bilirubin cannot be excreted in the urine. Gilbert syndrome can be precipitated by infection, stress, and fasting. So if a patient present to you with jaundice after fasting, then you will suspect Gilbert syndrome. You will advise him LFTs. What will be the result of LFTs? All liver function test will be normal. Only bilirubin will be raised.
Sir, what
And
is the
also,
age manifestation of the symptoms?
what is the?
Age.
Usually patient will present to you with at a young age, but as he has a UGT, decreased activity of UGT, so it can present at any age. Whenever he get infection or he do fasting or there's stress, his condition will be aggravated. So the symptoms are recurrent.
Okay.
It's usually a self-limited condition, which is manifested only in the case of infection or stress or fasting. Normally, the patient does not have any issue. Gilbert syndrome is a self-limited condition, even it doesn't require any treatment. And the only complaint the patient will present to you is yellow discoloration of eyes or skin or jaundice.
Can you
So
explain about the?
yes,
It's just the bilirubin. It's only raised because of the unconjugated. Uh, bilirubin. So, I mean, the mechanism of action, if you can just explain, please.
Yes, yes. There's an enzyme in the liver which is called UGT1 that is involved in the conjugation of bilirubin.
Okay.
So when there is decreased activity of this enzyme, bilirubin will not be conjugated. So unconjugated bilirubin will be increased.
Okay.
So this is the basic mechanism why only bilirubin is increased and all other investigations are normal. ALT, AST are normal.
And it is
Because there's
also.
problem
Mhm.
because there's problem with the enzyme that is involved in the conjugation of bilirubin, UGT1 enzyme.
Okay.
So can any one of you tell me any condition in which there is jaundice after infection and increase unconjugated bilirubin? Remember that in hemolysis, due to any cause such as G6PD deficiency, if you remember that in G6PD deficiency, patient also get develop jaundice after infection. How you are going to differentiate between G6PD deficiency, hemolysis, or no hemolysis? Hemolysis can be confirmed by reticulocyte count. If reticulocyte count is increased, it means the unconjugated bilirubin, the increase in unconjugated bilirubin is due to breakdown of RBCs. And if reticulocyte count is normal, then it means there is some other cause of this increase in unconjugated bilirubin. And in case of Gilbert syndrome, it will be UGT1 enzyme. So as I told you earlier that unconjugated bilirubin is not soluble in water. So urine dipstick in Gilbert syndrome will be normal. While there is another condition which is called Dubin Jhonson syndrome. In Dubin Jhonson syndrome, the patient presenting complaint is also jaundice. But in Dubin Jhonson syndrome, there is a problem of storage of bilirubin in the liver. There is no problem in the enzyme. So in Dubin Jhonson syndrome, conjugated bilirubin levels are increased because the chemicals that are involved in the transport of bilirubin are defective. So in Dubin Jhonson syndrome, conjugated bilirubin will be increased. So a person present to you with jaundice and his urine dipstick is normal, it's Gilbert syndrome. And a person present to you with jaundice with urine dipstick positive, it means increased conjugated bilirubin, which is the case in Dubin Jhonson syndrome. So in Gilbert syndrome, the raised bilirubin is unconjugated. In Dubin Jhonson syndrome, it's conjugated. In Gilbert syndrome, the urine dipstick is normal. In Dubin Jhonson, urine dipstick is abnormal. Dubin Jhonson syndrome, urine dipstick will show hyperbilirubinemia. Is it clear to everyone how to differentiate between Dubin Jhonson and Gilbert syndrome?
Yes, sir.
Now, as an example, see the scenario: 20-year-old male present with yellow sclera and skin, so jaundice after upper respiratory tract infection. Urine dipstick is normal, bilirubin is raised, ALT, AST, ALP, albumin, HB, reticulocytes are normal. Reticulocytes will be increased in which condition?
G6PD or hemolysis?
Deficiency. Yes. The increase in the unconjugated bilirubin that is caused by hemolysis, in that condition, reticulocytes count will be raised. Why not G6PD? In G6PD, there is increased reticulocytes, In acute hepatitis, ALT and AST are raised. Dubin Jhonson syndrome, urine dipstick will show bilirubin. Severe pain on defecation plus tender reddish blue swelling. Severe pain in defecation is usually present in anal fissure and hemorrhoids, thrombosed hemorrhoids, plus tender reddish blue swelling near the anus. So there is a blue swelling that is reddish in color near the anus, not inside the anus. So it's perianal hematoma or external thrombosed hematoma. It is not hemorrhoids because hemorrhoids are present inside the anus and they are painful only when they are thrombosed. Plus, in hemorrhoids, there is bleeding per rectum. Now, can anyone answer the scenario written in key 83?
Chronic pancreatitis.
Yes, excellent. It's chronic pancreatitis.
So episodic and remitting relapse.
Yes, episodic pain, remitting and relapsing pain, has visited the hospital several times in the last several months. So it cannot be acute pancreatitis because the history is of months. In acute pancreatitis, there will be history of days, 1 to 2 days. Serum amylase was gradually increasing, so it's chronic pancreatitis. Now the next case, in the next case, all the topics are repeated and our GIT chapter is finished. Tomorrow
So
we'll start.
in chronic pancreatitis, it's lipase. Sorry, it's amylase is increased, but in acute, it's li-
No,
lipase is increased.
in both
Mhm.
amylase and lipase are increased, but in
So what?
chronic pancreatitis they are mildly increased, while in acute pancreatitis they are 3 times the upper normal limit.
So while doing the investigation, what should we pick, like lipase or amylase?
Lipase is
Lipase is specific.
specific.
Lipase is specific in acute as well as in chronic pancreatitis. The only
Okay,
difference is that in chronic pancreatitis they are mildly raised, while in acute they are massively increased,
okay,
3 times the upper normal limit.
okay.
So our GIT chapter is finished, and tomorrow we'll start general surgery, and after that there will be a mock exam consisting of 50 MCQs, 25 from GIT and 25 from general surgery.
Mm.
So I'll see you tomorrow
All right.
with general surgery. Until then,